Good morning, and welcome to today's installment of Psoriatic Breakfast Briefings from ACR Convergence 2020 on Saturday, November 7th. I'm your Breakfast Briefings host, Alan Gaboski, Professor of Medicine at Weill Cornell Medicine and attending rheumatologist at Hospital for Special Surgery in New York. Today, I'd like to highlight two abstracts about diagnostic delay and delay in transition from psoriasis to psoriatic arthritis. The first abstract, 0308, is by Karmacharya et al., entitled Delay in Transition from Psoriasis to Psoriatic Arthritis, a Population-Based Study. Now, we know that psoriatic arthritis is a heterogeneous disease that may precede, occur concurrently with, or after the development of psoriasis. It's less difficult to define psoriatic arthritis, a true inflammatory arthritis, when the patient already has psoriasis, than it is to make the diagnosis of psoriatic arthritis when the patient is just presenting with joint complaints and there is no skin involvement. It underscores why it's important in the evaluation of patients with seronegative inflammatory arthritis to disrobe and examine their skin on each and every visit because of the possibility that skin disease may occur after joint disease in a significant number of patients. So this was a retrospective population-based cohort study aimed to identify demographic and clinical characteristics associated with the delay in transition from psoriasis to psoriatic arthritis. The CASPAR criteria were used for psoriatic arthritis, and patients were divided into two groups: patients with concurrent psoriasis and psoriatic arthritis, a confirmed diagnosis of psoriasis made by a dermatologist or a rheumatologist, or patients with psoriasis onset longer than a year before the onset of psoriatic arthritis. Of the 157 incident cases of psoriatic arthritis, the median lag time from psoriasis to psoriatic arthritis was about 260 days. 51% of patients had concurrent psoriasis and psoriatic arthritis. 49% had the onset of psoriasis before psoriatic arthritis. Among those who had a transition from psoriasis to psoriatic arthritis, there was a higher likelihood of family history and psoriasis severity than those with concurrent disease. Why is this important? Well, it's important to recognize two things. One, that patients with inflammatory arthritis who do not have skin disease on their first evaluation may well develop psoriatic arthritis in the course of their evaluation. And second, it also helps us understand that patients with joint pain who do have psoriasis may not have an inflammatory arthritis. In other words, not all arthritis in patients with psoriasis is necessarily psoriatic arthritis. Psoriatic arthritis is a true inflammatory condition which needs to be differentiated from patients with degenerative joint disease. And this can be done by carefully evaluating the patient longitudinally on each visit that they're seen. Now, the second abstract, 0309, from the same group, looked at diagnostic delays in psoriatic arthritis and identified demographic and clinical characteristics associated with delays to diagnosis in psoriatic arthritis. In the 162 incident psoriatic arthritis cases from 2000 to 2017, the median lag time from disease onset to a first confirmatory diagnosis by a physician was about 2.5 years. Patients who were younger at diagnosis, had a higher BMI, or enthesitis before diagnosis, were more likely to have a diagnosis delay of more than 2 years, while patients with psoriasis were less likely to have a diagnostic delay. Why is this important? Well, once again, it helps us understand the interplay between skin and joint disease and underscore the recognition that they need not occur at the same time, that one may easily precede the other, and that the specialist who sees the patient first may not be the specialist who makes the diagnosis of the inflammatory arthritis. And finally, it underscores the need for continued longitudinal evaluation of patients of both their skin and joints throughout the course of their disease.